Morning everyone. ఈరోజు టుడే we discussed four ECGs. This is the second one, this is the third one, and this ECG I didn't show you, so we'll discuss of the same patient. So he is a 72-year-old gentleman with a diabetic and non-hypertensive. He came with a history of breathing difficulty from last 3 days. He went to some nearby hospital and this is the ECG, so they referred to us for further management. Okay, so what is this ECG showing? I'll read the ECG for you. So this is a 12 lead ECG showing a regularly occurring P waves and regularly occurring QRS complexes with no relation between them, and the axis of the QRS is a right axis. Okay, and there is a RBBB type of pattern here in the V1. If you see the V1 positive is there, right? So it's an RBBB type of pattern. So today morning we had so much doubt regarding whether it's a Mobitz type 1 block. So many people after seeing this ECG, what they felt, see here PR interval is this much, it's slightly prolonged, here it's more prolonged, here it's more prolonged, here it's more prolonged, and here people felt something like a dropped beat. Okay, so this is not the way. Actually, if there is a dropped beat here, what should have happened? There should have been no QRS complex here at this point, and some junctional beat or some other beat would have been come. Okay, but what is the thing here? So many people did not see the P waves properly here. Okay, so now I'll show you the P waves for you. See, this is a P wave. Okay, and this is definitely a P wave, okay, but here a small bump, can you see? This is also a P wave. Okay, and this is a P wave, as you know, but what is this bump here? This is also a P wave. Okay, so next P wave has fallen here. This is the next P wave. The small bump, can you see here in the ST segment? This is the other next P wave. This is a P wave. Here somewhere, here P wave fell within the QRS complex somewhere here maybe, so it's not so clear, but P wave is somewhere here. So this is the next P wave, this is the next P wave, this is the next P wave, this is here, this is here, this is here. Okay, so these are all the P waves actually. So again, if you carefully see the ECG, this is the P rate. Then where is the what is the QRS complex? This one, this one, this one, this one, this one, this one. Okay, so there is no relation between the P waves and the QRS complexes. The QRS is just like it, the P waves are marching through the QRS. That's what we say usually. Okay, so what is the P wave rate here? The P wave rate here, it's around 100, right? Even more than 100. The QRS complex rate, what is it? The QRS complex rate is around 300 by 1, 2, 3, 4, 5 and around 45. Okay, so the P wave rate is around 120 and QRS rate is more than 100. Why this is happening here? Because the patient had a complete heart block, his sympathetic activity is increased. Okay, sympathetic activity is increased and the sinus node continues to beat at its fast rate, but the AV node is not able to capture because there is somewhere a complete heart block. Okay, so these are the P waves and this is the QRS complexes. There is AV dissociation and this is the complete heart block. Okay, so some more people have a different school of thought that it is a trifascular block. See, remember what is a trifascular block? When there is a bifascular block with a prolonged PR. So many people opined like this is a left posterior hemiblock. It means like positive leads in inferior leads, a negative lead in AVL. Okay, so along with a RBBB type of pattern. See, in V1 there is a M type of pattern and there is a S in V6. This is RBBB type of pattern and the axis is the right axis because lead 1 is negative and lead AVF is positive. So some people felt like this is a complete trifascular block. So but thing is, once if there is a complete heart block, okay, we should not comment, this type of terminology is not used here. Okay, so this is a RBBB and there is a complete heart block, but thing is this is not like a usual block because there is a RBBB. See, the possibility here is, so what what does it imply? A RBBP type of complexes with right axis deviation in a patient of complete heart block. So it implies that the the impulse is arising somewhere from the left bundle. Okay, so it implies that it may be an infrahesian type of escape. Okay, so that is the reason. So whenever such a ECG next time you see, you should never get confused whether it's a complete heart block or it's a some regular morbid type. See, the management completely differs. If it's a morbid type 1 block, the management is totally different, and you can just manage it medically with some stopping beta blockers or other medication. But if as it is a complete heart block, you should keep a immediate temporary pacing. Okay, so recognizing a complete heart block is very important. So whenever you see any bradycardia ECG, don't jump into conclusion that there is a relationship between P and QRS. See the subtle variations. See the shape. See, whenever you find a change in shape of QRS, see the shape of QRS here, see the shape of QRS here, see the shape of QRS here. All the beats are varying. The shape here is varied because the P wave is falling here. Here also P wave is falling. Here P wave is within the complex. So because of the P wave, the shape of the QRS is changing. Okay, so you should be very careful to observe a complete heart block, and you should never miss a complete heart block. Okay.